are here representing the Youth for SDGs campaign, which is a mostly online-based, right now, kind of public awareness campaign to engage young people in the SDGs by letting them know what they are and their significance, and then the most important part is giving them opportunities to help achieve these goals in their own ways. And so a couple of things we've got going on are these monthly webinars, and we've been doing them on different topics. So we've had one on just youth engagement in general, and then we're having this one, and then in December we might have one on the environment and what happened at COP21. And another aspect of our campaign is the 17-week campaign, which is a social media campaign in which we every week focus on a different SDG. We're just going in order. So right now we're on week 6, talking about SDG 6, which is about addressing water and sanitation for all. And we highlight an individual doing great things around this SDG, and then we make sure to provide a couple online resources for people to either learn more or get involved remotely, since a lot of people can't always dedicate all of their life towards addressing these SDGs. It's important to emphasize that you can do so in little ways. And so, yeah, that's what Youth for SDGs is. We're also hoping to launch a community ambassador program so that we can have more like local events where, because local is where the action happens. So people representing us at schools as like through like their student groups to host events about Youth for SDGs. Yeah, so I guess we'll go ahead and get started with the webinar now. Donovan, do you want to start this part?
Yes, thank you. Thank you so much, Rachel. I'm not great with technology, but very happy to see everyone here. Tonight's crowd, we have a bunch of really cool youth in the health field, sort of speakers that are going to be able to sort of set some context on different topics within health. The topic that we chose is health in a crowded world, which has to do with sort of the growing need for health access, and also the increasing population. How can you find the balance between delivering necessary resources for those that need it in the most marginalized places in society? So we're very excited to have this webinar. An honor to have our guests. Just to some introduction into the SDGs, as a lot of us may know, the Sustainable Development Goals are sort of a transition from the Millennium Development Goals, and that they are truly meant to approach development from 3 pillars: the social, the environmental, and the economic. And when thinking about that, it has taken a much more integrated approach in sort of addressing the global issues. And as mentioned, through local action. And through these webinars, we're hoping to raise awareness on different thematic areas within the SDGs. So today specifically, we'll talk about health. And while health is addressed in SDG 3, which says to ensure healthy lives for all at all ages, which, in a sense is very, very broad. But if you look at the details, there are indicators and targets that address a wide range of health issues, from maternal health, infectious diseases, non-communicable diseases, mental health, even neurological health. So a very wide range of issues are addressed. And one thing to keep in mind is that health in itself is much more than SDG 3. It really covers a wide breadth of issues and is interconnected. And that's really what we want to understand today through the webinar. So I'm not going to take too much longer. Just to highlight some of the topics we'll be covering. First, we'll have an introduction, a little bit deeper introduction to health in the SDGs. Then we'll go into more the environmental and social determinants of health and how those factors can influence either the lives of people or the access to healthcare. Then we'll have sort of an interactive session where we try to model health systems in a crowded world, and what do we have to keep in mind in terms of accessibility of health, timeliness of receiving health, and quality of health. And then at the end, we'll sort of, in the second hour, we'll cover how can we sort of learn more about health education and how can it propel us to act as youth in this sector. So now I'll turn it over to Wally, which is one of our colleagues, and he can introduce our wonderful speakers, and looking forward to the discussion ahead.
So again, hello everyone. My name is Wally. As I mentioned in the chat, I'm representing Engineers Without Borders, and I'm also representing the Millennium Campus Network. So we are very fortunate to have several members here to join our discussion. So I will go ahead and introduce them, and feel free to add anything else. I'm sure we'll learn more about you as we go through the discussion. But we are joined by Moa Hergard, who is a medical student in Sweden. She's with IFMSA, which is the International Federation of Medical Students Association. I know we have several representatives of the IFMSA here with us today. And she's also a deputy organizing partner of the Disaster Risk Reduction Working Group for the UNMGCY, which is the major group for children and youth. We also have Lily Lukic, who is a doctor and representing the Croatian Institute for Public Health. He's a projects division director, also with the IFMSA, and he's on the Advisory Council of Youth and with the Ministry of Youth and Social Affairs and Government of Croatia. Thirdly, we are joined by Sam Straits, who is pursuing an MPH in biostats at BU. And she is an intern with the WHO on the team of medical devices covering policy, access, and use unit of the Essential Medicines and Health Products Department. And lastly, we are joined by Sam Lee, who's a Bachelor of Medicine and studying general surgeries with the Lancet Youth Commission for Essential Medicines, also with IFMSA, the Hong Kong group. And do we have one more? Yes, and fifth, we have Cornelia Masaviciute, who is with Vilnius University as a medical student, also representing IFMSA. So, like I said, a lot of IFMSA representatives. So for all five of you, we can begin the discussion, I guess by just to provide some context, a couple moments to talk about your path to passion in health and in sustainability, what really got you involved in the work that you're doing, what builds your passion. We'd love to hear about that, just to provide some context before we jump into the specific themes of today.
So we can start with Moa, if you want to go first. Just we're just going to go around, and if each of the discussant speakers can, in just 1 minute, their experiences in health and why they're so passionate about it. We'd love to hear that.
Yes. So nice to meet everybody, and I'm from the same, but I was in the form for really hard. It's a bit of but on regards of health as one of SDGs, as you all know, but Donovan as well is one of SDGs specifically addressing health.
Well, the connection is not very good. Noah, can you hear us? Hmm. Well, maybe if Noah sort of tries to reconnect, if you know Sam and Straith and Sam Lee and if you want to share and Lily as well, sort of why you're so passionate about health and why you entered the field, you know, just for 30 seconds, 1 minute, we'd love to hear that. So, do you want to start, Sam Straits, or?
Hi, sorry, Donovan, are you calling for me?
Oh yeah, sure. I was calling for the other Sam.
Okay.
That's okay. You go ahead.
No, you should go ahead first. Don't worry.
Okay.
I'll be next.
Hi, everyone. My name is Sam. During my undergraduate years at BU, I was studying economics and international relations. But the thing that really got me interested in public health was going on a alternative service break during spring break to St. Jude Children's Research Hospital in Memphis, Tennessee. And basically there we were volunteering at the Target House, which is a home for children and their families who are receiving 3 months of care or longer at St. Jude. Going into that environment, I just realized this was a group of people that I really would like to spend my career working with. They were extremely passionate, and I really think that just the goal of ensuring a healthy future for children and just for everybody was really important, just because health really does impact every part of our lives. So I had internships in a medical setting at Boston Medical Center. And then most recently, I was at the WHO at the headquarters in Geneva this past summer, interning, as Wally said, on the medical devices team of the Policy Access and Use Unit in the Essential Medicines and Health Products Department. And one of the major projects I was working on there, two were, one was with health technology assessment and the other was with local production and technology transfer of medical devices. And I can go into that further later when we dive more into the discussion, and just talking about sort of some of the ways that the SDGs came about from and the kind of struggle to have every voice heard when forming the SDGs, and also the impact that the SDGs have on the future of public health, at least for the next 15 years.
Thanks so much. That sounds wonderful. Sam Lee, I guess you can share now.
Sure. Thank you so much again. So I'm a medical student in Hong Kong. Last year, I took a gap year and kind of interned also in WHO headquarters. I was interning in the human resource for health, basically dealing with education and training for health professionals. And then I also did an internship in the United Nations Relief and Work Agency for Palestine refugees, in which we have a project to look into different medications that the Palestine refugees are taking across the fields. And we did analysis and to see what kind of factors are driving for their access for those essential medicines. And taking a gap year allowed me to have more time to join other student activity. And the Lancet Youth Commission is actually one that we've been working on with Lancet. Basically, we want to try to reframe why we are fighting for access for essential medicines and what is the relationship with it, with universal health coverage. And so the main reason why I'm really interested in promoting health is that as med students, we always have time for the clinical stuff, but we always forget that there's always a much bigger picture up there. There are policies, there are determinants which affects our health, and even as non-health professional, we always have a lot of opportunity to advocate, and to really participate in the discussion. So looking forward to telling you more later then.
Thanks so much, Sam, and definitely we can learn a lot from your experiences. Lily, do you want to tell us just a minute? I guess you're already a doctor, but if you want to share with us what makes you so passionate about the medical field and health.
Well, I guess I have to feel passionate now because it's my career. Of course, I can always change it, but it would be inconvenient. I graduated basically 1 year ago, but I've been really active in last 7, 8, 9 years with a lot of community projects. I grew up in Bosnia just after the war, and so I've seen a lot of underserved populations, or like not even the underserved populations, periods when the whole population within the country was underserved when it comes to health or any other services. And one of the things that started to make me rethink my goals of being a cardiosurgeon to going to a place where I wanted to be working more with public health and more in community setting was my exposure to post-war areas in Croatia, where we as medical students just went and saw people who haven't seen doctors for 10 years because of a lot of social determinants of health and political or gender or human rights determinants of health. And this basically started something in me to try to do something about it, which led me to being involved with the youth health national strategy planning through the National Youth Council, the Ministry of Social Affairs and Youth, and I've interned with the WHO this year just to learn more about what can the actual international organizations, international community do for local and national level and policy making. Because one of the things that I've seen through the work with local and national and NGOs and with international NGOs is this link, and would just get blurred or would be really thin when it comes to government and actual change that obviously in most of the cases needs to be systematic and needs to be policy, and it needs to be implementation in the level of the governments and not just connecting the governance with the policy and with the implementation of the policies. Yeah.
Very nice. Thank you so much, Lily. And I think the breadth of experiences between all the panelists, I think it's quite wonderful, and it's going to help enrich the discussion in the next hour and a half. So thank you to all of you. Just to highlight, I think Moa has connection issues. I think she just traveled to Malta and doesn't have good Wi-Fi. So I'll just fill in for her a little bit. When we say that health is a cross-cutting issue in the SDGs, what we're trying to say is that, as alluded to by those who've spoken so far, is that health is much more than just medicine. It's also the society. It's also the environment. It's also peace and stability, because that promotes health within countries and physical health communities. You also have SDG 7, which has to do with energy. How does access to energy help promote services of hospitals or community health centers? And of course, climate change with the COP21 coming up. What are the effects of air pollution, changing ecosystems on our health, the air we breathe, or vector-borne diseases that can be spread through the environment. So a lot of different sort of interlinkages between all the SDGs and health really as a interconnected issue. So what we want to try to do today is try to really understand the different components of health. And the way we want to start with that is by looking at the environmental and social determinants of health. and this was already mentioned a few times. And we have sort of one question to sort of guide the discussion, and then we want everyone to sort of participate and see, which social environmental determinants have more of an impact. How does the context or the setting affect how much of an impact it has? So what we're interested in seeing is, how does a person's status, whether it's socioeconomic level, whether it's their status as humanitarians or refugees, which is very big in the news recently, or how does their status residing in an urban versus a rural setting influence their exposures to different social and environmental factors, and how does it influence their behaviors that subsequently determine not only their health, but their accessibility to quality health. So I hope it's a good guiding question, Lily. We'll let you sort of give us a little bit of an introduction, since you've experienced and learned a lot about this, and then hopefully we can make it more of a discussion.
I think you kind of gave an overview of the environmental or social determinants of health that are often linked with something that's called political determinants of health as well. Since some few years ago, there was a commission on political determinants of health that proved that, for example, better health outcomes are seen in certain political systems, like in democratic political systems, rather than some others. But at the same time, you would have a really high and good-looking health outcomes in countries such as Cuba. There is communist communist political system, but still the health outcomes were really good compared to some other democratic countries with democratic systems. So I think a lot of things like individual lifestyle factors, or the way how we behave, the way how we interact with other people, and as well our community networks affect a lot what we do. For example, or even employment policies, working environments is where you have working policies like countries that don't have paid leave, or that have to think about being laid off from work if they go and see a doctor. So even in the countries where all the people have access to primary care, still they wouldn't use it because they would just not be able to leave the work, because they would have to choose between having to pay for their family for housing, having to pay for food, or having to pay for not having cough. So they would rather have cough and continue having cough for, 10, 20 days and not get diagnosed with TB early enough, rather than leaving work and not earning money for their family. This was one of the striking things that I've learned during my work in WHO, was how big of an impact environmental and social determinants have in all of these conditions. Which is interestingly enough is that at first, when the social determinants of health as a term started to emerge back in 2008, when the first reports have been made by one of the biggest WHO commissions, there was no mention in environment together with the social determinants or socioeconomic determinants. But this environmental conditions and environmental determinants have started to be kind of impossible to be linked from the socioeconomic and as well cultural differences, as you've noticed, as you know from the outcomes and the discussions about the outbreaks of Ebola, how much culture, how much religion, and how much different anthropological related issues had an impact on the outcomes of people. This is one more kind of determinant that should be taken into consideration when discussing this. So what I think is really important to stress here is that it's not only health system is not the only kind of pillar in the governance, in national level or local level that has to bear the health outcomes. The health is the issue of all the other so many sectors. So this is why WHO and some other institutions are promoting health in all policy approach, and this is something that has been quite reflected in SDGs compared with the MDGs, where in MDGs you had 2 or 3 really health-specific goals, while now you have health and well-being goal, and health being mentioned all over the place with health co-benefits and coming from the influence in climate change, then housing co-benefits, health co-benefits, as you mentioned, rural and urban differences, and then environmental, like air quality, like sustainable environment, agriculture, or healthy or sustainable our waters, our seas, our land. How much of all of these can actually, interventions in all of these fields can have impact in the health. And this is, I think that this is where the secret kind of for health impact lays, because health usually does not bring that much money. That is obviously, yeah. I don't know if I covered kind of broadly what could be just to give a.
Sure. I think you said a very good context for the discussion. Thank you so much, Lily. And I very much appreciate that you expanded not only the environmental and the social, but also, as you mentioned, the economic and the political, which has also a factor in the cultural, which is very pertinent. So if there are any sort of discussion points, if anyone sort of has reactions to what was said or wants to add or ask questions.
I wanted to just jump in and talk about, like, while I have little experience on public health, I am always interested in how such a like cultural and like such a like central to a society's culture aspect of health can be like assisted by people coming into the region who aren't of that culture. Because all of those factors are so based on what people are accustomed to, and so it must be so foreign to somebody for somebody from the Western world to step into their town and say, I'm here to make you healthy. So for anybody who has experience in helping to set up health systems and improve access to health in either more rural places or places still developing, how does that work, and how do you make sure that you're considering all of these different determinants?
So if I can just tell from my experience is the areas that I worked in Croatia were with population that was older people who stayed there after the war in Croatia, but they were of the nationality that was the Serbian nationality. Basically, they were the people on the other side of the war. So they didn't flee the country. They stayed in the country. So they had a lot of resentment towards anything that's Croatian. They just wanted to be in their houses, and they just wanted to live in their gardens and not have to have anything with Croatians. And one of the issues that we had were basically when we knocked on their doors and said, "Yeah, hello, we are medical students. We would really like to talk with you and perhaps see if we can help you read how do you use your medications, or if we can measure your blood pressure," which was the goal of the project at first. We literally, people would just close the doors. They would think that we wanted to steal something from them, because for them we were their enemies, because Croatians killed their children. But in some time after, I think the most important thing is to learn about why these people are feared, or why these people might not be open to you, because one of the first rules would be for you yourself when you come to be open to what you're going to do there, because if you know something and you know something good, doesn't mean that this is the best way to do things in a certain environment. Something that has been done in the case of the Ebola, and one of the reasons why the whole shift changed, and one of the reasons they say why it finally started to get better, is that all the guidelines, all the regulations that have been made by WHO, by MSF, but even the MSF was really, really, really good in response, and who was really aware of the cultural and religious issues. Still, there was a lot of gaps with burial, for example, and with even the idea of being sick, So I think the biggest change was made when people said, "Okay, yeah, we will listen to you. Tell us what you think is the problem, and then let's sit together and make decisions, make plans together." Because one other problem that we often do as young people, we want to change something, we want to help, want to see some impact that we leave, but we often don't ask the feedback from the people that we are actually providing the support, and learning from their feedback, using the feedback.
I think that's a great point, and one of the things that intrigues me most as it pertains to providing aid, I guess specifically in the field of health and even just in the broader scope of development, is Lily, you talk about that complexity where, where the aid that is provided should be very feedback driven, because if it's not, then there's a lot of room for it to kind of fall short of the expectations if it's not really catered toward the feedback received from a receiving community or a receiving party. The complexity, I kind of feel like, comes into play where, a lot of times if the aid providers have a technical background, or they have a medical background or a policy background, and they come into a community, although they don't necessarily go in having the feedback of the community, they do have a bit of a technical background that the community does not. So I always wonder, this is just something I always wonder in general, is how do you kind of maintain the balance between being able to draw community feedback and develop according to what they feel is best, while also offering a perspective that they don't have. So I guess as a possible example, if you look at the issue of clean water and how that affects health, while very subtly there may be an issue caused by a lack of potable water, and the long-term diseases caused by that issue for generations. At the same time, while a community has been dealing with this issue for generations, they don't necessarily see the need for a solution, because they have had that same fixture in place for such a long time. Whereas aid providers coming in would come in with that perspective where they know that there is an issue with the water. So although the community feedback may not encourage a solution, I feel like there's a level of I guess you could say flexibility where the feedback can also be met with some technical background and expertise. And I wonder how or what the best way is to kind of maintain a balance between those two things.
I think that having the facts and putting something as a fact, as something as a proof, often helps. And just putting everything on the table, putting the problems of the community and putting the problem, what the technically skilled people think that, or have evidence that it is a problem. For example, I know for a fact that until this year, they never had clean which is related to there have been zero guidelines of what healthy housing should look like, or what kind of parameters should have a healthy housing should have in order for every to have a perfect health, or to give the best of the house to enable to have a perfect health. And one of the discussions that were this was done by my department when I was interning in WHO, and one of the discussions was, because of differences, you cannot have can you have the same housing or same guidelines, same kind of threshold for all over the world, for Dubai, Doha, where you have 50 degrees in midday during summer, and as for example Norway, or for Ecuador, or for Ghana, and then the conclusion was, let's just put what we say, this is the evidence, this is what the healthy house is, what the healthy housing is. And then you work together with the governments, you work together with, or in case of WHO international community, or we work together, governments would work together with local communities, with cities, to see which of these things can be implemented in the setting that is happening. Of course, we cannot think that we can just do things like that. For a lot of things, it's just a process. You just start doing things just do it step by step, and what we can do now, but at the same time plan what can be done in 1 year period, 5-year period. And I think why it's important here to stress the strategic planning of all the decisions, and which is often not, especially when it comes to politics, is a weak point. I didn't touch that much of a wash, but I think it's quite related. I don't know if that answers it.
No, I think it's a great point, and it's actually quite relevant. And I think the suggestions you're giving, and I think the mindsets that we have of having a more comprehensive approach and a more bottom-up, empirical approach to ensuring good health is sort of becoming more influential in the UN system. Also, because there's for those of you who know, the Habitats 3 process on urban housing and settlements. And it's meant to develop a new urban agenda at a conference next year in Ecuador. And one of the big they have a few thematic areas, and one of them is basic services. And within basic services, they talk about health services and how does urbanization and spatial planning of cities affect the access to health. And in terms of WASH, it's interesting also because yesterday and today is, I think it was Thursday and Wednesday, Thursday was the high-level days for water and sanitation at the UN, and World Toilet Day, and they also covered some of these issues in terms of the intersectionality of water, sanitation, and their effects on not only health but also nutrition, which has the impact has effects on health and child growth. And I think that they had mentioned that 65% of stunted growth in children is due to poor nutrition because of unsanitary hygiene and sanitation. So it's very interesting how all these sort of determinants are linked in different ways. So very cool. Does anyone else have comments or feedback? I don't know, Lily, I don't know if you're about to speak, but
I just want to echo Lily's point about political determinants, and I would like to talk about my experience with the Palestine refugees. My department was doing sort of like an audit. So what happened is we found that nowadays, after decades of the Palestine problem, nowadays our refugees, their main cause of death really is the non-communicable diseases, and we found that a lot of them are actually obese. So the department did an audit of diabetes care and to look at what happened to their lifestyle and their medication, etc. So I remember there was this example. We were asking this refugee, how come you don't do exercise? How come you don't eat well? How come you keep smoking? And then as we were trying to ask him, the refugee go on and say, because I'm very worried about my son, because my son is now being jailed in Gaza. And this is one example that, for example, in Hong Kong, if I want a patient to really take exercise, if I really want him or her to live a healthy lifestyle, it is completely different than telling a refugee in Gaza, because the political determinants have affected their way of living. I mean, not only am I talking about the security of the family members, not only am I talking about food security, there are a lot of things that the blockade, for example, by Israeli military in Gaza may have effect on the healthcare provision, for example, the supply of medicine. So, so it's really ironic because my department, the UNRWA, United Nations Agency for Palestine Refugees, they try very hard to strive for the health of Palestine refugees. But at the same time, there are a lot of determinants that it's really unsolved. And I think this is also a source of inequity. If a place cannot live in peace, or if a place is full of injustice, there are a lot of things that we ordinary healthcare providers really cannot do. So that just to highlight the political determinants.
Yeah, I think like the what sense that is really important that the security of all the different is not that stressed. Is not definitely not stressed enough. One thing that I learned is that it's how hard it is to change the habits and to change the behavior, and this is where most of the struggle is, and this is why a lot of implementation or a lot of field actions and policies or means of implementation are using incentives to try to motivate people to change their behavior, because they don't know any other, there's still, no one has thought of any other better way to motivate people to change their behavior. And some other ways that have been proposed, like different changes in taxes, not directly to the people, but for example related to sugar policies, or what has been done in Europe on tobacco control, is usually some really hard things to do, because there is a lot of lobbying from the industry, there is a lot of all of these side things that kind of push government to in a way not do good for their people, even though they want to do good for their people. So they use the incentives, and they don't, I don't know, higher taxes on companies who, or close the companies who produce tobacco, because their economy of some countries depends on tobacco production. So yeah, it's I think it's really complicated. Something like just because I had to leave soon. One thing that I really learned from experience that I learned was working with the Advisory Council on Youth, in which I was one of the 7 people from the youth-led NGOs from Croatia. I was representing medical help young people, and we worked together with, we sat together with all the ministries and representatives of local government, so like municipalities, NGOs, some relevant agencies, for example, for education, for So what we did is that we worked on the national strategy on youth. We worked on this for 2 years, and one thing that I learned is that we often see only people who are in a way institutionalized, like are in some kind of institutions. You think of people who are working, who are employed. You think of young people who are in school. You think of kids who are in school. You think of good ways to, good interventions of, I don't know, older people who are in some old people homes, etc. But one of the biggest challenges is how to, even with good policies and good implementation plans and strategies and action plans and actual good implementation, there is always this gap, whether something is available and is accessible to certain groups of people, but still for some reason they are not reaching it. They're not using it. And this is one of the problems we had when it comes to the people, young people who are not employed, who are not in school, and who have, and those are the ones who have the poorest health of all the young people. And but at the same time, those were the ones that were not using any of the services that were available, free for them, accessible, and
That's very interesting. No, thanks so much. It links exactly to what Sam talked about in terms of the health inequities and how there's not only inequities in health access, but the inequities within political systems or in socioeconomic levels, or all those other factors have an effect on the health. So I know you have to go soon, so I don't want to keep you. But we wanted to, especially thank you for providing your context and sharing your experiences with everyone else.
Thank you for inviting. I was really glad to share about what I've learned, and I'm sure a lot of other young people are doing really awesome things.
Definitely.
I'm gonna share my email if someone wants to contact me.
Oh, perfect. Thank you, and hopefully we're going to continue the discussion with whoever is here and try to dig deeper into the different components of health systems and the different determinants, and how can we sort of model that and see what is the how do you achieve a sustainable health system. So we'll see how far we get with that. So to continue the discussion, I guess one question I had, and maybe we can transition, is do these determinants or the skills or the impact of the determinants depend on whether you're dealing with infectious diseases versus chronic non-communicable diseases, since their causes or their root causes can sometimes be different. So I was wondering if anyone had thoughts on that, on sort of the relative influence of these non-medical determinants on health regarding whether it's infectious or non-communicable?
Jonathan, this is a very interesting question. I would like to share. Okay, so let's take Ebola as an example. Ebola is itself a disease that comes from the natural environment, and it is now considered that itself actually came from animals, the so-called fruit bats. So as you remember in the Ebola outbreak, people were advised not to take bushmeat because somehow the fruit bats will transmit the virus to the bushmeat, which is then consumed by the locals. And it was postulated that this is the root of the transmission from animal to human. So this is the story of Ebola. So now is the question. For some countries in Central Africa, the consumption of bushmeat and fruit bats is very important for two reasons. The first reason is it is a very important source of their protein. If they don't eat the fruit bats, they don't really have a lot of choice of sources of nutrition. And the second reason is it is really a kind of the culture of hunting down those fruit bats and those wild animals. So you come to a dilemma that somehow you have to understand that they have to take in those nutrition, and it is their cultural thing to hunt down the wild animals. How are you going to stop them from contacting the wild animals? Because you know that those wild animals are full of viruses. You don't know what kind of new diseases can kind of wait ahead. So apart from Africa, let's take a look at Asia. In 2003, there was a new virus called the severe acute respiratory syndrome virus. It was a very famous outbreak that started in southern part of China, which then spread to Hong Kong and the rest of the world. So this virus actually, now we know that it is also from bats, and it is also transmitted through certain wild animal that local Chinese consume. And the recent cases of avian flu, which is the virus carried mostly by birds and chickens and ducks, is because the reason why those viruses become transmitted to the human transmission chain is because we have close contact with them. In southern China, there are a lot of wild animal markets which are really packed, and they're really popular because the local Chinese really love eating those wild animals. So how are you going to stop the emergence of those emerging and re-emerging infectious diseases if the locals are really into this kind of delicacy, right? So in terms of infectious diseases, I think this is a very good example of how our cultural practice actually affect our risk for not only the past but our future incidents of new infectious diseases. Yeah.
Thank you so much, Sam, for this very thorough example. I certainly didn't know the whole story behind the Ebola, and I think what an interesting thing is the trade-offs that can happen between these different components in our lives. Are you going to the trade-off between getting the source of food or potential risk of becoming sick, and the trade-offs between the social factors, environmental factors. And I think when this is sort of transitioning to the next part of the discussion, when thinking about health systems, and like we talked about, there's the policy aspect. What can governments do either at the national level or at the municipal level to implement policies that better improve community health, but also in terms of innovation and technologies, what kind of devices can be developed, and how do the social determinants also affect the facilitation or spread or scaling of technologies in different societies. Or, I mean, it's a big question of supply chains as well. And I think, Sam, you probably did this in your internship, so maybe you can give us some feedback. But, you know, when considering all these different things, and when you have people trying to build these health systems and understand, well, which point of intervention will have the most impact, right? I mean, I think there's also a question of limited funding, and there's only so much to cover. You know, where are you going to invest the resources that you have and the funding that you have to optimize the health system as a whole, without trying to reinforce one aspect of the health system at the expense of other parts of the health system. And this comes the issue of trade-offs. You know, what decisions do you make? What are the bottlenecks to achieving these, you know, more resilient health systems? So I mean, I think it's a big question, but hopefully we can try to decouple some of these interlinked challenges and hear what people think.
Yeah, so I can go ahead and jump in terms of the medical devices and technology side. So I think in terms of bringing it back to the SDGs a little bit, over the summer we noticed that like language plays a big role in developing something like the Sustainable Development Goals, just because a lot of the actual vocabulary that's included in the SDGs is going to be used to for future research projects or for future funding opportunities. So for instance, medical devices and technologies is not specifically included in SDG 3. So there's a few different targets. For instance, Target 3.8 elaborates on this goal to achieve universal health coverage, which includes financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. And I think a lot of that goes back to the economic side between the pharmaceutical industry and between the medical devices industry, in terms of there's so much more money in the pharmaceutical side. And even at the WHO, within the essential medicines and health products department, the essential medicines side of pharmaceuticals has such a greater representation than the medical devices team. And that the medical devices versus the pharmaceutical side of trying to bring these different technologies and pharmaceuticals to the places that need them the most. And I think in terms of when we were talking earlier about when, say, someone sort of from the Western world goes to the global South or so and tries to implement maybe a technology, that there really is a lot to learn from these countries that don't have as many resources, just because in the West there is so much money that is wasted when really technologies that are on a very high level technology, but the same result could be achieved with the lower level technology that would save a lot of money that could then be allocated to a different part of the healthcare system. So I know I touched on a lot of different topics, but in terms of sort of how, also going back to Donovan, to your question of how a person's status influences their exposure to having that access to health, it obviously, as we all know, it really does come down to sort of money and strength in numbers. And especially in the pharmaceuticals industry, this is really seen the infectious disease side, but also on the non-communicable disease side too, in terms of money for insulin and other pharmaceuticals related to diabetes right now is a really hot topic. So but I think from a youth perspective, that just goes to show that our voices are important. If there's a part, say, I know some of you have a biomedical engineering background on the medical devices side. Yeah, it's really important to bring your voices to the table to say, you know, with medical devices are a huge part of access. If we are spending so much time focusing on essential medicines and pharmaceuticals, we need these medical devices to even be able to receive these pharmaceuticals in a lot of these settings. So I think it can be a little discouraging looking at how the landscape is right now, but it's also encouraging knowing that our voices do count and we can make a difference.
I think I have a direct response to that. I think I agree. It's said that the SDG does not really include everything. But I would just like to point out when we talk about the access to quality and safe medicine, we also talk about the rational use of medicine. And a lot of time, in the correct way, we actually support from, for example, point of care diagnostics. So I know, Donovan, you are working on your project, on your diagnostic tool. And I think this is very important, and it is intrinsically linked to the use of essential health services. Because, delivering the pill, the drug, is indeed very important. But a lot of time, what we lack on the field really is a very easy to use and very direct and reliable diagnostic tool. So I hope that this sheds a little bit more light to respond to your point that the SDG does not really reflect everything. And I would just like to bring the discussion a little bit broader, and because we also talk about universal health coverage, right? One way to look into UHC is to consider it as sort of like a cube. It's three-dimensional. So the first axis, we have what kind of population, like to what extent do we cover the whole population? And then the other axis, we have what surface are we trying to cover? And then the third axis is to how much do we cover the cost of that intervention, and that is to how much of the cost should be paid out of pocket by the patient. So if you think of UHC in these three axes, everything makes sense. And when we try to, so basically UHC is really trying to extend this towards the three dimensions and to make the cube as large as possible. And your point about pharmaceutical is interesting because the problem of access right now, the hot topic really is the high price of medicine. Nowadays, we're going towards a more higher prevalence of non-communicable diseases, including cancer. And cancer drugs are really, 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 really expensive. And I'm not sure if you know the recent hepatitis C drug, sofosbuvir, which is very effective in curing this horrible hepatitis disease, which can be very chronic, costs actually $1,000 per pill. $1,000 per pill, and this really raises a really serious discussion about if we want to cover all the people in the United States for this drug, so the whole health system is going to be bankrupt, right? And I think this is something that we as young people need to be aware of. We are going to an era that we need a lot of medicine that treats chronic conditions, but they are very expensive.
Yeah, definitely, Sam. I certainly agree with the cost of medicines is so extraordinary, and it's definitely a cost that's out of reach for a lot of people, especially in the US if they are not on health insurance. And I think that it really comes down to, in terms of the high price of medicines, is really looking into sort of these alternative research and development models. A lot of times pharmaceutical companies can argue that they need to make the cost of a drug so high because then that money can go back into researching and developing either a better medicine or a medicine that can target a different non-communicable disease. And also looking into, I know Doctors Without Borders is really looking into the push-pull-pull method right now for sort of a more collaborative approach to pharmaceutical research, and also just in terms of the licensing and patent regulations, maybe shortening the patent time so that this research is then available to other pharmaceutical companies to be able to improve upon an existing disease. Medicine for disease. And then that also comes back to, in terms of for infectious disease, how there's so little incentive for pharmaceutical companies to be looking into medicines that target these infectious diseases, just because they know that they won't be receiving as high of a return as they'll receive on a lot of these other medicines targeted more to diseases that are found in the Western world, but also increasingly in other parts of the world as well.
I'm glad that you sort of both brought up sort of ethical issues around the access and delivery of medicines, and is it ethical that pharmaceuticals charge so much for these different drugs, or is it justified based on I guess you mentioned the research models and what they do with that funding in terms of R&D. So I think there's also a similar problem when it comes to scaling, even if it's a drug or some access to healthcare that's very cheap, but then you go into a low resource setting, resource limited setting, and you want to introduce this either new technology or, I know Sam Lee from Hong Kong, being on the Lancet Commission of Essential Medicines. I mean, those are, aren't always too expensive. But then when you come to the scaling issue, that's where your health system isn't resilient enough and sort of breaks down. And sometimes it's problem of access or delivery, because populations are so sort of far away from health centers. But essentially, from your experiences, what are sort of techniques or interventions, or what do you have to keep in mind when you think of scaling these sort of needs for the population as a whole?
What do you mean by scaling exactly?
So essentially, there's a certain drug for, I don't know, hypertension, or you would know better, or diabetes. Essentially, you can bring it. If it gets imported from somewhere or developed, you can have it in the big cities, in the capital. But how are you going to make sure that it gets into the most far-reaching places of these low-resource places, into the rural settings? And there's problems of transportation. There's problems of refrigeration of drugs. And the question is, whose role is it to ensure that there's proper scaling so that everyone who needs the drug or the technology has access to it in a cost-effective manner, right? Is it policies that get implemented by governments, or is it subsidized by private sector? Is it the user that has to, incur some of the costs? So I don't know if I'm setting the question right.
Sure. Yes, this is actually a very interesting question. It's also very specific. I'll give you an example. In 1980s, when HIV medicine were very expensive, and even after the price went down, people start to ask a question, a very, very stupid question that you might feel very angry now as I say it. People start to ask, in Africa, people don't have access to good doctors. They don't adhere to the regimen of antiretrovirus, because HIV requires strict adhesion to the treatment. Otherwise, there will be a high incidence of resistance. So there are a lot of excuses at that time that we shouldn't increase the coverage of antiviral for HIV in certain countries in Africa. So, which is really ridiculous, because there are a lot of ways that you can deliver the medicine to the community. So first of all, there is really no evidence that rural or distant populations do not adhere to medication. There's simply no evidence to support that. Secondly, there are actually a lot of ways to deliver medicine. For example, the role of community health workers. It was shown in Haiti that the use of community health worker, which is actually specific health workers who are less trained than health professionals, but they are trained for a specific purpose, and in this case, the delivery of HIV medication. There is evidence that it increases the coverage, and it also improves the adherence to treatment for those HIV patients. So to answer your question, how do we deliver the medicine to the distant population? There are two tiers. First is a very good procurement and supply chain management to fully ensure that the quality and the quantity of the medicine reaching those populations are sufficient. And secondly, are to develop specific programs with specific skill mix of health workforce. And in this case, if the population, the rural population, do not have enough doctors, why not train a group of dedicated people, the so-called, be it non-physician prescribing or be it the community health workers, to help deliver those medicines. I mean, there's always ways for us to overcome the problem of rural and distant population. I'm not sure if you answer your question. It just reminds me of this debates regarding the HIV medication.
No, sure, definitely. No, I think that definitely sort of getting to the answer and providing more context.
Yeah, I think it's interesting because the question not only applies to drug delivery, but really any sort of implementation as it pertains to rural settings, in any level of aid delivery. How can you be thorough enough that you're not just addressing city areas, but also less accessible areas, whether it be drug delivery or any other initiative that pertains to aiding these areas. And, more often than not, the rural settings are the ones that need the most assistance in addressing basic human needs. But I think supply chain management is, really invaluable as is empowering certain individuals within communities and giving them the technical background and the education in order to sustain their work. And I was fortunate enough to have traveled to Zambia this past summer, so I was able to see some of this kind of in play, to a certain scale. But I gained an appreciation for how it's really a matter of baby steps on the ground. Especially with these rural areas, you can devote a whole program to one specific rural setting, and then there are tons of communities directly around that kind of are forgotten. So I think that's where our biggest challenge is, on one hand, these supply chains and these other fixtures in place are very important, but I think you talk about the power of numbers. There needs to be a dedicated initiative to motivate people, I feel, to replicate these solutions, these supply chains, and these systems, across all rural communities, because I think they are often the most forgotten, and they're the ones that need the aid the most. I think that might be the biggest challenge is these systems can be developed very successfully at the top, but in order to allow them to drive all the way through past urban areas, I think that it's really a matter of manpower and motivating more and more people to get involved in aiding community after community and helping them be sustainable in their solutions.
And Jonathan, I have to relate your project to this discussion again, because I know you've been working on the point of care diagnostic. One of the biggest barrier that, for example, NSF nowadays might face is that they don't have the necessary diagnostic tool for tuberculosis or multi-drug resistant tuberculosis in certain areas. And so that's why there has been a lot of initiative to develop the point of care diagnostics for TB on the field. I think I can send it to you, send information to you later, because I know a group of scientists actually are working on training the mouses, some mouse to detect the blood of patients who have tuberculosis. So this is a very interesting and innovative way of low cost but very reliable diagnostics, which are actually lacking in a lot of settings, especially in rural areas.
Yes, definitely. Thank you for remembering my project. So, for those, I guess, can give some more context. So, studying biomedical engineering, we're working with a few people on developing a paper-based fluidic point of care diagnostic device for early screening of thyroid disease, specifically hypothyroidism in young women of childbearing age who are often susceptible to fluctuations in thyroid levels, which incurs both a health risk both on the mother and also the child. So no, thank you for connecting that, Sam. We're definitely, as we're developing this device, we're asking ourselves, there's sort of the back end, which is the chip. When you're developing a microfluidic device or microfluidic chip, a paper-based chip, which is low cost, and the advantage is that it requires very little sample from the patient. So it's not very invasive, and also it can be administered by almost anyone since it's very simple and gives a direct output. In order to have a sort of screening or response like right away, instead of waiting several weeks of sending tests to a lab center, waiting for it to come back. But one of the biggest things we're trying to look at is sort of the front end, which is the actual design of the device, is the human interface, the user interface. How are we supposed to know what the local context is that optimizes that user interface? How are they comfortable using the device? So that's sort of what we're trying to look into at the moment. But it's such an interesting discussion. Does anyone else have different perspectives or complementary thoughts on the discussion of health systems? I know this was a little bit specific, but even more broadly is fine. If you want to share.
If you can hear me all right, I'm in quite a noisy place actually.
No, we can hear you.
That's perfect then. Hey everyone, it was quite interesting to listen to all the discussions previously. With sharing Lily's experience in this one right now in terms of quite different contexts and different ideas that are happening. I would think in general that just to be a little bit of a devil's advocate in this discussion, there is another side of I think quite a big challenge is that health is actually a huge business in any kind of sense. And since in nowadays kind of world, it's all the values are going more in a materialistical side as much as we would like to be altruistic. But it's just like going rapidly in industrializing and corporatization of everything. And in terms of health, I think that is one of the huge challenges is that health is actually a business, and it generates a huge income for the companies, for medical sites, for private hospitals, private entities, and even your merchant pharmaceuticals is one of the really, really good examples on that, as well as any kind of industry providers, caretakers, and it's quite really hard to overcome this. Not even if we look not only in the developing countries where we need to go more back to the basic side to get the essentials there, but even looking to the more, let's say, developed side where there are still huge gaps between in terms of the social determinants for health, just because it plays on a profit rather than that kind of a altruistic side. And yeah, as Donovan's saying, health is a human right. That is definitely a human right. But I think there has been a lot of seeing that we can, how can people benefit from that human right? And unfortunately, that's what is really thriving nowadays and gives a huge challenge. Just to pitch that idea.
Yeah, that's a great point, Courtney. Really, expanding the perspective a little bit. The motives aren't always, it's always to improve well-being, but there's also ulterior motives, which it's hard to sort of I mean, you could justify, but when you do this issue comes up of health as a human right. I mean, yesterday it came up also with water and sanitation, and there was a big push in the SDGs for goal 6 for universal access to water and sanitation to have water and sanitation as a human right, which is actually not the language they use in SDG 6. They use it in the declaration, not in SDG 6. But there was a huge sort of push from different organizations. I know the MGCY pushed for that as well very strongly, that water is an inherent part of our life and social well-being, and also the environment, so it shouldn't be neglected and be made affordable, be privatized. So I definitely think that for health, it is definitely also a human right, but there are so many different constraints and trade-offs that can happen. So thanks for adding that to the discussion. You have to go?
Yeah, I just wanted to pitch in goodbye. Coming and going.
Not formal, it's kind. Thank you so much for saying that before leaving.
It was. Yes, I'm really sad for leaving. That this was a definitely good time spent. But in terms of, I think we should have more of this, and I think we will have more of this. So yeah, definitely lovely to see you, hear you all, and see you the next time. Sorry, I have to leave.
Yeah, thank you so much.
Bye, everyone.
Talk to you soon. So does anyone want to continue the discussion? I know there's a few people on the call who haven't spoken yet. If you have any input into the discussions or different perspectives, but please feel free to jump in.
One thing I was curious about, and I actually don't have a whole lot of context on this, so I was wondering if everyone on the call who has perspective on the policy making side, I do find that in a lot of contexts, be it the lesser developed world or the developed world, there is always this very recurring issue of a lack of investment from the private sector. And I feel like if you kind of incorporate that into this discussion, then you have the potential to solve a lot of the economic and financial struggles. And I think that theme is recurring, whether you're looking at sub-Saharan Africa or even America. And so for that reason, I was wondering what role policy plays in kind of tying in and inviting and kind of maybe hoping for investment from the private sector, and what potential that has in solving at least the financial shortcomings that kind of impede further development in a lot of these discussions and a lot of these themes. If anyone can give input on that.
Yeah, I think there are a lot of different models that haven't been fully explored yet in terms of being able to shift investment and sort of the financial incentive to work more on issues that are more relevant to the global South in particular. And I don't know where that, so I know that the WHO and the next World Health Assembly in May is looking, just because pharmaceuticals is kind of what I know the most about, in terms of this issue, but is looking for these different models, and in terms of asking that member states, part of their contribution to being a member state in the WHO would be shifted to the pharmaceutical research and development side, and trying to incentivize more research and development to go into these pharmaceuticals. But I don't think anyone is arguing that a lot of these pharmaceutical companies, they should be able to recoup part of their profit from developing these medicines, because a ton of time and money and resources do go into bringing a drug from phase 1 all the way out until it's delivered to the population, the target population. But definitely the profit margin for these companies is just totally inequitable. And as Donovan was saying, the health as a human right. I definitely think more regulations and policies need to be put in place so that these extreme profits can be shifted into other areas.
Oh, thanks for that input, Sam. You guys go to the other Sam. Sam Lee, I don't know if you're still on the call, but you mentioned that you had worked in, more humanitarian refugee settings. In those contexts, how much do policies have an effect, since they're not sort of in institutionalized settings, compared to health systems that are run by countries or governments? I mean, again, I'm not very knowledgeable on this, but it seems for humanitarian settings and refugee settings, they don't really get the local aid, the local governments to aid. So what is policy making different in those settings rather than other sort of types of health systems?
It's very different. So UNRWA is actually it's a very strange system in that it is actually itself like a government itself. It oversees the a health service, basic health service for Palestinian refugee across Syria, West Bank, Lebanon, Gaza, and Jordan. And in terms of the difference with other member states, the service they provide are really basic. I mean, for medication in diabetes, I was asking my supervisor in the health department, why do you have this basic drug? Why don't you have a better drug? And the answer is, they simply don't have the money. I mean, the whole agency have to care for over 2.1 million Palestinian refugees on very limited health budgets. And the health budget is actually very dependent on member states' donation. Many a time it is not very sustainable. So for refugee, the problem is really, you really need to be careful about where you spend your money. Primary health care is a very powerful coverage tool, but many a time the medicine they give to refugees may not be the best. For example, we all know there are a lot of medication for hypertension, but the way they select the medicine, the so-called essential medicine list and their formulary, is basically not taking consideration of cost effectiveness. It might be cost effectiveness, but the most determinant factor really is the cost that the agency can afford. I'm not sure if this is exactly the same for UNHCR, which deals with refugees other than Palestinian refugee, but I would guess that it is pretty much the same issue.
Definitely, very interesting. To understand how the context again dictates a little bit your ability to access health, and sometimes it's out of the person's conviction or efforts, but rather the environment and the settings in which they find themselves. Which I think is sort of unfortunate, because just because of the place that you're born into shouldn't dictate the amount of resources or the quality of the resources you're able to receive. Oh no! So I mean, in terms of I think I may have another sort of aspect to it, is when we think we're talking about health systems. So if we want to think of developing resilient health systems, what does that mean? I don't know if it's too broad or too specific or both at the same time, but what does it mean to have sort of a resilient health system, and what core components that you have to keep in mind. For example, coherence between policy and what happens on the ground, or enough access of trained and skilled workers, healthcare workers, or is it being a certain distance of a health clinic or a district hospital, so I'm just sort of trying to contextualize what would be needed to put into operation a resilient health system. And it can be more vague than specific, but I think it might be interesting if we just each talk about what we think the components should be and should be taken into account. And after that, conceptually, that's sort of how you build the interlinkages and the trade-offs, and how you can sort of model that. And the modeling comes into place, I think, is if you have an understanding of your health system, you can identify where do you want to invest your limited resources to have the best overall impact, whether it's going to be with the delivery or the quality of medicines or the number of skilled workers, the technology or policies. So yeah, I don't know if it's too broad, but I think this will be sort of the last transition as we try to put everything together, from addressing the non-medical health determinants, but also ensuring quality healthcare. So.
Sorry, I just wanted to say bye really quickly, and thank you all for the discussion.
Sure. Okay, Sam. No, thank you.
Yeah. Bye.
Talk to you soon. So, for those who are here, just I guess 5-10 minutes, and then we'll be finished. If you have thoughts on that.
I have a question. I don't know if you were getting to this later on, but for someone like me who is not as familiar with health systems and everything, what is something I can do right after this call to, advocate for global health?
Sure. That's a great point. We're definitely going to get to that after this discussion in 5 minutes. But if we can try to answer that now.
I can answer both questions.
Thank you, Sam.
It's a really broad question that you bring. I would just like to introduce a term called HTA, Health Technology Assessment. It is actually a tool used by a lot of European countries. So what it means is whenever there's a new intervention for an existing problem, health HTA is sort of like an analysis that compare the intervention options and take into consideration the cost, the effectiveness, and also the political and social impact of those interventions. Thailand has a very interesting example of HTA. It's called HITAP. It's called Health Intervention Technology Assessment Program. This is a very powerful tool at the policy level to really determine whether to include certain intervention, be it new technology in diagnostics or a new drug. So that might be the question. That might be the answer to you wanting to put everything together, because this might be the best way for us to understand whether an intervention is really beneficial to the society. And to answer your second question, like what you can do after this webinar to for health system, I think fundamentally we need to advocate for equity, and we need to advocate for the fundamental drivers of inequity behind. I would just like to use access to medicine again as an example. How come some people around the world do not have access to the life-saving medication that they should be provided with? How come the pharmaceutical system the global pharmaceutical market, if you look at the figures, actually less than 5% of the profit of pharmaceutical companies come from low-income countries, like a lot of countries in Asia and Africa. How come they charge $1,000 per pill for hepatitis C treatment to high-income countries, which is really crazy because nobody can afford that? How come there is no or little research for diseases, for neglected diseases, simply because it does not generate enough profits for the research and development? So a lot of things that were discussed and raised today are basically inequity and the fundamental problem of our research and development system and the way we structure healthcare and the way we prioritize. So I would say that advocating around this area, it's something that everyone can do and everyone can understand. So I hope this answers your question.
Yes, that was great. I love how you framed it as like my role can be just asking like the how come questions and just kind of investigate these drivers, as you call them, of inequity. And I think you're right, that will have broader implications and more specific like health system issues that maybe I don't have the expertise to advocate for, but it's something I can still contribute to.
Yeah, and just to echo what Julene said, I think you have a very nice way of presenting it, Sam, and I think it comes with experience. But
well, to be honest, I don't really have a lot of experience. I just have
the passion.
I guess interest, like really asking my question. How come this is so ridiculous?
Definitely.
Yeah.
And I think I think it comes first with a shift of perspective from profit-driven healthcare to more human rights and human-centric driven healthcare, and really changing the paradigms of how we approach our models in healthcare, and in terms of what can we do. As you said, Sam, addressing the inequities is sort of the root cause, and learning about them, educating ourselves and others, and advocating for those inequities to be closed. And I think it's especially interesting just because since health is a cross-cutting issue, there are so many different ways that people can advocate for that and can address these health inequities, because even if it's someone who has more of an environmental background or someone who has more of an economic background, they can address those determinants of health and inequities that are found within that domain. For example, climate change and our actions towards the climate, and advocating for improved climate, and sort of what's happening in COP21, the big climate conference in a few weeks. That will have an inherent effect on, the non-medical determinants of health. So I think, whatever background we have, we should also use that and see how, closing the gap of inequities in that domain will have an effect on healthcare as a whole. So.
We have a question from Kim Horn to everyone. Why don't we advocate to the UN to tie SDGs with financial aid, which are provided by the World Bank, the IMF, ADB, etc., to developing countries? And maybe the people who have had some exposure to the policymaking side can give some context on tying the SDGs with financial aid.
I don't know, Sam or someone else, if you want to answer that. I have a partial answer, but if you think you have a better answer, please feel free to do go ahead.
Hi,
Hello, how are you?
I'm good. How are you?
Good. We're so in the last part of our webinar. Thank you for joining.
Oh, you're welcome. I just came from class.
Oh, very well. Thank you. So I'm going to give a partial answer. I don't think it's the full answer because I don't know the process as well as others. But hopefully, we can try to do some of the research and maybe send you some links afterwards if you give us your email. But I know that in parallel to the SDG process, there's another process called financing for development. It was a similar sort of intergovernmental process where the biggest impediment to achieving these SDGs is financing. So there was a big conference on financing for development in July in Ethiopia, in Addis Ababa, where they sort of laid out, I don't think they've sort of finalized it, but certain parameters, or how are these lofty goals going to be financed? Because at the end of the day, if you want to engender change and change that is meaningful in our lives, especially through programs and interventions that cost money. I don't know the specifics of the World Bank, IMF, and all that, and the Asian Development Bank, but I know that they're implicated in this financing for development FFD process, which is meant to complement the SDGs in terms of the operationalizing and financing of initiatives over the next 15 years. So it's a very surface level answer, and I'm sorry I can't provide more, but like I mentioned, please send us your email, and we can definitely try to give you a few more links to dig a little bit deeper on that. But I don't know if anyone else has an answer for that.
The way I understand to finance SDG related to health, which is what we talk about, universal health coverage, is really the essence of that is the financing within the national government. So it is encouraged that the member states find their own way to develop a strategy that can lead to their own sustainable financing for healthcare. So in that context, I'm not very sure what's the sustainability or the use of money from the World Bank or IMF, because if you want to talk about sustainability, you really need the member states to figure out how they are going to have the revenue of all the budgets they spend on health. Some countries may find it more better for public health insurance. Some countries might be more into a mixed picture of private and health and public health insurance. So I think it really depends on the context, and what we're trying to advocate for is to reduce the out-of-pocket payment of patients by a sustainable financing mechanism within country. And I think that's about the financing of for universal health coverage. Now, I don't have a complete answer as well, but this is how I understand.
Yeah. No, thank you so much for providing that point also, that you want the national, since each member state and nation deals with such different contexts and different types of healthcare and needs. They want to sort of build one that is fit for the purpose, that is fit for their needs within their population. And some communities might deal with much more higher rates of infectious diseases or non-communicable diseases, or what it may be, or even the environmental landscape of where these different countries are found can affect what kind of diseases and health access is needed. So at this point, I think we've had a very exciting and interactive discussion. I just want to open it up for anyone who has questions in the next 2 minutes, or final comments based on our discussion. Feel free to sort of interrupt us. Either final questions or final comments or feedback.
I think one thing that's really kind of overarching in this discussion, and really in every discussion as it pertains to the SDGs, is that no one goal is isolated from the others. And I think you can't really solve the shortcomings in global health without considering the fact that the contributions of other themes and factors. And we talk about health systems, something that I really did not have much exposure to prior to this discussion, but it's, it kind of, you visualize a broad chain map where everything is very interconnected, and how, the decisions that are made, in a conference about energy or environment are not exclusive to just those conversations, but they also have major implications on health. And I think there's a real beauty in how interconnected everything really is. So, for those of us who are interested particularly in the growth and development of global health, I think it's incredibly important from a youth's perspective to strive to not only gain context on strictly health, but also the surrounding contributors that really factor into that discussion. And so, be it just involvement in overall policy or specific contributors, whether it be urban health or environmental factors. I think there's a lot that goes into that, both in just general global development, but also with health specifically.
Thanks, Wally. So, Kimko, one last question. Does the WHO has their own pharmaceutical laboratory to address new epidemic disease? And why does it depend on the private sector? Well, it can be a whole discussion itself. I mean, Sam, I don't know if you have a good way of answering this concisely. I mean, I know you've done an internship with the WHO, or am I mistaken? But
yeah.
So maybe you have a better context to, either. Yeah. So if you want to either answer concisely or provide a reference, because I'm sort of not sure, but please go ahead.
So in terms of WHO, so I would advise you to take a look at the WHO Global Health Observatory and the so-called discussion on the consultative expert group working group for financing for research and development. So basically what's going to happen next March 2016 is that WHO is going to call for an informal consultation among member states to have a research and development treaty in which member states are expected to commit to a sustainable financing mechanism for setting up innovative way to finance the research and development to really answer the healthcare needs of many low and middle income countries. I'm not sure if this answers your question, but WHO, I think, does try to take a lead in to close the gap of not having enough money for research and development for infectious diseases and other diseases. But the basic problem now we face is the fundamental problem of our R&D system. It is too profit-driven, and so that's why we've been calling for a new way of R&D model, which is called delinkage between the cost of developing a medicine and the profit of that certain medicine. So it's a huge discussion behind, but we can look forward to next year. So hopefully something do happen regarding this WHO R&D treaty.
That sounds awesome, Sam. Thank you. Very nice. And if you have any last comments as well for us, we especially want to thank you and the other discussants that were on the call today. We're no longer here, but we really want to thank you for your insights as well into the discussion. You're welcome. I mean, it's really fun. I mean, it's really nice to see you see all
connections, and I think I've learned quite a lot of things here as well. I look forward to welcoming you to our next webinar and WHS working group regarding access to medicine. And I think Donovan, you already registered, right? So,
yes, I did, and we'll make sure to. We're going to share this video with our campaign page and with others since the recording of it, and then we'll make sure to also link it with the webinar that you'll be hosting, and just I think on Saturday, is it?
This coming Saturday, yes, 28th.
Yes, definitely. So we'll make sure to link people as well to continue the discussion even further. But thank you so much again, really, for all your insights. And I know it's getting late in Hong Kong, so don't want to keep you too much longer. But if anyone else has feedback or comments before we leave.
I just want to say thank you to whoever is still here for joining. That was a really, really fascinating conversation. I learned a lot, and you guys covered some really important topics like ethnocentrism and inefficiencies in pharmaceutical industries, and I'm very glad that I was able to hear all that insight from everyone. And yeah, I hope to see you all again at the next forum.
Yeah, sure. Thanks so much, Julian. So now it's 11, so just want to thank everyone yet for coming, and hope to see you soon again so we can further the discussion on this and other points within the SDG. So hope you all have a wonderful morning, afternoon, or night, depending on where you are in the world. But really have a wonderful day, and thank you again for joining. Bye-bye.
Bye.
Bye.